Yeah, I think so.
Okay, give me just a second. If people still joining. Hello, everyone, and welcome to today's webinar, The Path Forward, Recentering Our Work in AOD Prevention Post-COVID. My name is Orlando Cooper, one of the graduate assistants at IHEC, and I'll be your moderator. I'm assisting Madison, the Assistant Director for the Illinois Higher Education Center for Alcohol, Other Drug, Violence, and Prevention. We are very excited to be hosting today's event. Before I hand over the event to our presenters today, I just wanted to inform everyone about CHES and the credit. We usually send out certificates 7 to 10 business days after the event. And then usually at the end of a month or two, we send out the CHES credit. If you haven't sent me your CHES number, my email is at the top of my name. You can email me with your information just in case. So other than that, I will pass over the presentation to our presenters today. So the floor is all yours, guys.
Thank you, Orlando. Hi, I'm Joan Masters. I'm the project director of Missouri Partners in Prevention. We are neighbors to our friends at IHEC at the Illinois Higher Education Center. We are the statewide coalition in the state of Missouri of 24 campuses. You'll actually be hearing from me in part 2 of this presentation, which is on Thursday. But I just wanted to do a brief overview of what you might see in our presentations moving forward. But first, we will introduce ourselves. And so again, I'm Joan Masters. I'm the project director for Missouri Partners in Prevention. I've worked with the coalition for about 20 years, and I will have my 2 colleagues who are joining me today, Kaylee Greenwood and Margot Lightshoe, introduce themselves now. Kaylee.
Thanks, Joan. Hello, everyone. I'm Kaylee Greenwood. I'm the full-time research coordinator here at Missouri Partners in Prevention. So I deal mainly with our mock-being data as well as some well-being data that we collected in the winter, fall of 2020, 2021. So that's what I'll be presenting on today. And then I will turn it over to Margot to introduce herself as well.
And I'm Margot Lightshoe. I'm the communications coordinator with Partners in Prevention. I've been with PIP for about 5 years, and I work on a couple different grant projects that we have related to impaired driving prevention, suicide prevention, and prescription drug misuse. And you'll be hearing from me sort of in the second part of the presentation.
Great. So just a few housekeeping details. We are happy to answer questions throughout. We do have, we have several staff on here, and we'll watch the chat as needed. So just let us know if you have some clarification questions. We will take a break in between part 1 and part 2 today. So Kaylee will present first, and then Margot. If you could just make sure that you're muted on your end, you're welcome to be on camera if you'd like to be, or you can be off camera, that's fine. And then if you have any like technical issues or questions, I would assume those can go to Orlando. So just to get started, so when we first put this presentation together, it was about 6 or 7 months ago, and we were kind of feeling a little bit like we were moving out of COVID and COVID's hold on higher education, that when we returned to campus in the fall, we were really going to be able to refocus our work outside of just handling COVID 24/7 in the campuses that we work on, that our health centers and our counseling centers were going to get a little bit of a breath. Well, Omicron changed things, and we had this presentation scheduled now for January, in which some of our campuses are exclusively online learning again. So what we will say is that what we hope is that this information will be good whether you use it now or in a couple of months. But what we aim to do is to really look at the data that we've collected in Missouri Partners in Prevention. As Kaylee will mention, we do have a survey of 24 students on 24 campuses in our state that really looked at, it really looks at the alcohol and drug misuse concerns for college students during the pandemic, and then what we believe we will see post-pandemic. Additionally, we believe in order to really recenter ourselves on doing evidence-based, data-driven prevention moving forward, we need to most definitely implement the strategic prevention framework. It's something that guides our work in the state of Missouri. And part of the way that we do that is also by taking stock of our own cultural humility and our cultural competence. And so Margot is going to be sharing more about the social determinants of health approach and how that works to inform our work in the state of Missouri, but how you can use that same approach in your work moving forward post-pandemic, as we deal with really what is a dual pandemic, the rising mental health concerns among our students, the rising health concerns, in addition to the pandemic itself. And lastly, on the last day, which is on Thursday, we will tie it up by really revisiting the strategic prevention framework and specifically looking at how you can start to rebuild relationships related to AOD prevention or to strengthen existing relationships related to AOD prevention using a coalition-based approach. So we'll break down every aspect of the strategic prevention framework, talk about things that you can do as you choose evidence-based strategies moving forward, and that will be sort of how we anchor our presentation. So really, I think the title of today could mean a lot of things. And again, we do a lot of consulting with our campuses, so we're happy to go off script a little bit and try and do whatever's helpful for all of you. But this is what we're focusing on for today and Thursday. Next slide, Kaylee. So again, just to note that these are the 4 presentations we will be doing between today and Thursday in part 2. Next slide. A little bit of background about Missouri Partners in Prevention for those of you who do not know about our work. We are the statewide coalition made up of 24 colleges and universities in Missouri. We're funded by 3 state agencies, the Missouri Department of Mental Health, the Missouri Department of Transportation, and the Missouri Department of Health and Senior Services Office on Women's Health. We work with our campuses to design data-driven, evidence-based strategic plans to address the health and safety issues, the primary well-being issues on their college campuses through a variety of funding and support and strategic technical assistance that we provide to them. Next slide. So our technical assistance that we provide includes funding directly to our campuses to advance strategic plans for prevention. We do a great deal of technical assistance and professional development. Kaylee will talk significantly about our data collection, both in the Mock-B, which is our annual survey, as well as she noted, our well-being survey that we did mid-pandemic. We help all of our campuses with the coalition building that they need to do in order to move their strategic plan forward and make best use of the funding that we provide. We do a great deal of networking and advocacy for the campuses so that they can be sort of tuned in to the things that maybe might make the most difference as they're building coalitions and moving forward. And lastly, we do a lot of ongoing technical assistance to the coalitions on our campuses and prevention professionals. In our group of 24 campuses, we have 2 historically Black colleges and universities. We have 8 private institutions, 2 two-year schools, one of them being a 2-year technical school. And we also serve the needs of campuses in the coalition that are religiously affiliated, and we have all of the public 4-year universities also in our coalition. So we do a lot of very specific technical assistance to campuses based on their needs. And so chances are that if you have questions related to how some of this information might relate to your campus and your individual campus needs, it's likely that we've maybe worked with a campus with your unique structure because of the 24 campuses that we work with in our coalition. Next slide. So just a note, I mentioned before that we use the strategic prevention framework, and this will be something you see come up quite a bit. If you're not familiar with SAMHSA's strategic prevention framework, then fantastic. Thursday will be just right on time for you. This on the left is the strategic prevention framework. It is a secular model of planning for prevention that runs from evaluation and assessment through determining capacity for the work that we do, planning and then implementing. And it's tied together by a focus on cultural competence, or a term we prefer to use, cultural humility, and a focus on sustaining those things. And so in Partners in Prevention, we actually have several things that we do at each of those stages of the SPIF to assist our campuses. And so you'll actually be hearing about a lot of those as we go through today. The work that Marga will be presenting on related to the social determinants of health is tied directly to the work that we do to try and assist our campuses to use a lens of cultural humility in the work that they do. The work that Kaylee will be presenting on is tied to our assessment and evaluation work that we've been doing with the campuses. And so again, you'll start to see as we build our presentation moving forward, some of these things that we do often in Missouri Partners in Prevention as we support the state. So in Missouri Partners in Prevention, just to set the stage, we believe that prevention should be 5 things. It should be balanced and it should be comprehensive, meaning that any plans that are done on a college campus, whether it's related to substance misuse, mental health, violence prevention, or even addressing bias and discrimination, that plans to move forward should be both balanced and comprehensive. And balanced means that we can't just focus on the needs of pre-matriculated college freshmen or students who live in the residence halls or students who are members of fraternities and sororities. We must think about the multitude of needs that students have throughout their lifespan. The way students might think about, say, cutting back on nicotine use is going to be different potentially for a freshman than it is for a junior or senior that's looking for jobs. And so the tactics that we use, the support that we provide must be balanced and comprehensive. We also must think about comprehensively the fact that students don't drink and use nicotine and use cannabis all separately. There's not a different group of tobacco users as there is a different group of alcohol users. At least our data in the state of Missouri really notes that the critical health behaviors that our students are engaging in that are most detrimental to their academic success are incredibly intersectional behaviors. Students have a lot of co-use and poly-use of drugs and alcohol, and their co-use or poly-use often is affecting their mental health. It's affecting how they feel about their university, their interest in quitting school, etc. So it's important to think about these behaviors not in separate silos, but all together in one concept of well-being. Thirdly, our work must be evidence informed. We are past the stage where we can do something because we think it will be fun or students will like it. Some of the most critical health behaviors that our students have are not going to be solved by making students happy. They may be solved by making students a little bit uncomfortable with the work that we do. And maybe that is holding them accountable for a behavior, referring them to counseling and getting help. And so we want our campuses not only to focus on things that they want to do or historical or maybe that they've always done, but most importantly, rely on evidence-based strategies. Take their cues from things like the College AIM, which is our very useful set of tools that tell us what we might identify moving forward as useful strategies for after we've collected assessment and built our capacity. Additionally, while we want to choose evidence-based strategies, maybe those strategies that others have evaluated for us, we want to evaluate it for ourselves. We want to identify if this strategy works for our campus, and if it works well on the neighboring campus, but it doesn't work well for our campus, and that's okay. We want to be able to evaluate it. Again, you see the SPIF really informing the conversation that we're having here. And lastly, and most importantly, really the reason why we do what we do is that prevention is a shared responsibility. It's shared between the student and all of the community members, because the student is not solely responsible for their behavior in college. The environment is very much responsible for the choices sometimes that college students make, whether positive or negative or detrimental to their health or health supportive. And lastly, all stakeholders. That's not just those of us who work in prevention. It's those of us who work in counseling centers, health centers, Greek life, fraternity and sorority life, residence halls, police, and campus ministers. We all share the responsibility of moving forward and developing a plan of action when it comes to our students' most critical health behaviors. So now I will turn it over to Kaylee as she looks a little bit closer at the data that we've collected so that we can build a case for why we are pivoting out of COVID and moving forward, focusing on our substance abuse and mental health work.
Perfect. Thanks, Joan, for that excellent background. Again, my name is Kaylee Greenwood. I'm the full-time research coordinator here with Missouri Partners in Prevention. So our first kind of set of presentations will be titled here, College Students, Alcohol and Other Drugs and COVID, a deep dive into our data. So first and foremost, I'll give you a brief look at kind of where I'm headed with this presentation. So I'll give you an introduction of the survey data that I'll be referencing and then kind of delve into kind of part one of that data. I want to provide some room, since the slides are very data focused, to kind of have some breaks throughout and some opportunity for dedicated time for discussion and asking questions. So we'll have a break first for those. We'll delve into some more data and then have another question break. And then finally, we have some lovely campus partners who have agreed to kind of share how they've used some of the results from our survey on their campus, especially highlighting kind of the data specifically and moving forward with that evidence-based approach that Joan mentioned. And then we'll leave it open at the end for kind of a final discussion and wrap up before a break for Margot's presentation. So that being said, the data that I'll be covering today is from our 2020 Students' Wellbeing Survey. So I know you may be thinking 2020, we're in 2022 now. We do have our 2021 MOCB data, which I can discuss here in a moment. But really the survey came out of, we were still very much in the depths of the pandemic. We recognized, however, that our students were going to be coming back to campus and starting to try and kind of implement a back to normal lifestyle on campus. And so one of my previous colleagues at Pitt, Dong Ding, had the excellent idea to kind of do a climate survey in the fall called this Wellbeing Survey, to get a sense of how students' alcohol and other drug use may have changed throughout the course of moving online and off campus in the spring, being at home potentially or in a different living arrangement over the summer, and kind of how that's impacting their fall experience. And so we'll have some data to compare as well to our 2020 and 2021 MOCB. So the MOCB is our much larger Missouri Assessment of Collegiate Health Behavior Survey. We are gearing up to implement this year's right now. So it's done every spring since 2007. It's an online survey. The questions match up very nicely to the Wellbeing Survey. It's just a much longer survey that covers more in depth the concepts of alcohol, drug use, both prescription and illicit, interpersonal violence, mental health, and tobacco. So we'll have kind of some touch points to compare to the MOCB there. But again, the main focus is on the Students' Wellbeing Survey data. So the survey itself is open for 1 week from about late to mid-October. And we had 13 of our 24 PIP campuses participate. So it was about a 19% return rate. This gave us an overall sample of just over 5,400 students. And again, it was a much shorter survey, about 75 questions, and we also allowed for a lot of open text options so that students could really share their experience and concerns. And then broadly, the areas, again, that the survey covered were demographics, stress and mental health, alcohol and other drug use. We also included some questions about physical and mental safety, as well as access to medication, again, thinking about how students' living arrangements and who they were living with may have shifted as they were removed from campus and then brought back on. And we also asked just some general questions about how students felt with their university's COVID-19 response and prevention strategies. So all that being said, we'll get into some actual data now. So again, just to take a look at who those 5,400 students who participated were, and any comparisons to the MOCB 2020 or 2021 data. Also only look at those 13 campuses who participated in the Wellbeing Survey. So these are at least the same schools in all of these groups. But you'll see, at least for age, we had exactly equal the same breakdown that we did for the well-being survey as compared to the mock-B. A little heavier, 60% of these students were under 21, 40% were over 21. The majority of the sample was women at 60% for the well-being survey. We had 40% students who identified as male, but we also had about 1.8% in both surveys identify as gender non-binary, and a little bit prefer not to respond. For the questions of gender, sexual orientation, and race, however, you'll see a note that all of these are check all that apply questions. So we recognize that students may identify as belonging to multiple genders, sexual orientations, and race. And so students who are in one of these categories may also be contributing to some of these other percentages as well. So similarly for sexual orientation, the majority of our students in both surveys identified as heterosexual, and then the majority of our students, 77% in the well-being survey, identified as white, but we do have 22% of students who largely overall fell into the group of students of color. So looking first at living arrangement of our students, and there are a couple of questions associated with this aspect of the survey, but looking first, we asked them to report where they lived from March to May 2020. Again, thinking of
Our apologies. The presentation is frozen. I think Kaylee had some internet issues. So we will give her just a few minutes to come back on. Or Margot and I can share the presentation.
Hello, sorry everyone. Let me reshare my screen here, and then I will likely go off video here moving forward, just to try and help that connectivity. Can you all see those slides okay? Are they presented normally?
It's your PowerPoint, like we see.
Like the notes and everything?
Yeah. Mhm.
Okay, let me. Is that better? Different? No.
Change.
Let's try this. How's that?
Oh, there we go. Yep. Living
Okay.
one.
Okay. All right. So yeah, I'm going to pop up video here and see if that helps. Apologies again, everyone. So I'm not sure potentially what the last thing you heard was, but again, looking at where our students were living kind of in that transition period at the end of spring semester 2020, the majority, 76%, said they were living with parents or other family members. 15% said they were living with a spouse or other partner, and then 11% with a roommate or friend. But what we see is that in fall 2020, again, once school was back in session and for all of our Missouri campuses, at least, classes had returned to in-person, we really see the roommates and friends and parents and other family members switch. So much less, only about a third students are still reporting living with parents or other family members, whereas almost half are now living with roommates or other friends. Folks who are living with their spouse or dating partners remain the same. And then we see a slight increase in the number of students who report living alone. And so when we look at a couple of other aspects related to living arrangement and kind of trying to tease apart more specifically where these students are living, we see in that March to May 2020 period, which again, the majority of these students reported living with a parent or other family members. That was in Missouri, but potentially in a different city or town in their college or university. So again, not in that same town where they had been going to school. 10% were living off campus housing in the same city or in terms of the number of students still in the town that they go to school in. Largely when students are back in person in fall 2020 to having 30% back to living in the residence hall. Still about 39% off campus, but they're
Kelly, we're having trouble hearing you.
in the same city or town at least as their school.
Kelly? We're having trouble hearing you. Okay, folks. I am not quite sure. Let's see. I apologize. We usually do not have this much trouble with our internet all at once. Let us, maybe Kaylee, if so Kaylee has gone out. I think I will start sharing and maybe that will help.
Hi, sorry. So sorry, everyone. I've normally not had this many issues with my Wi-Fi.
Kaylee, how about if I share and you
Okay.
can just tell me next slide, maybe if you can be off internet and not.
Yeah.
Is that good? Thank you very much, Kelly, for your kindness in the chat.
Appreciate your patience, everyone.
Okay. Just one moment. Kelly, do you see it?
Yeah, it's still like I see not presentation mode, but I see the slides.
Is that better?
Yeah, there we go. Okay, perfect. Thank you.
Mhm.
All right. Apologies again, everyone. We will see if this mitigates any Wi-Fi issues. So kind of as I was saying, I think right as I got cut off there, really wanted to highlight the differences in living arrangements for these students kind of while they were off campus due to COVID and then as they came back in the fall, just to highlight that this may likely have affected their potential substance use behaviors. Again, if you picture them being in on-campus housing, residence hall, or even off-campus housing, still in the same city or town as their university, that may have different impacts to their substance use compared to if they're living at home or, living with other family members, especially as we can see it really did shift to a majority of students being back in their college town or back in an on-campus housing situation when they returned in the fall. And we'll start to see a bit of that manifest in the data here moving forward. Next slide, please. And so we also just wanted to take a quick gauge in the survey of how our students were experiencing COVID. So again, this is probably largely out of date now, but I think it's important to see in the context of the data we'll be presenting that at least at the end of September 2020, 90% of these students had not been diagnosed with COVID-19, but 64% of them had to quarantine or isolate due to illness or exposure related to COVID-19. So again, these may be drastically different now. If anything, they're probably higher in terms of quarantining and higher in terms of having been diagnosed. But still paints a picture that largely all of these students have been affected by COVID in some way as they took this survey. So we'll delve into now, first looking at some mental health and substance use overview. So just to kind of orient ourselves here with the legend. So these green bars are going to be questions related to in the past year. So that was our MOCB 2020 data that was before March 2020. The yellow bars are this well-being data. So again, this was the survey asking your experiences from March to May 2020. And then these green bars are in the past 30 days. So really looking at fall 2020. So we have before the pandemic, before March 2020, while we're in the pandemic, and then fall 2020 back on campus. So we can see that stress levels reported in the past 2 weeks as being either overwhelmed or unbearable. So these are our highest stress level students. We're actually higher before March 2020 at 35%, and then they've dipped a bit kind of from that March to May to 30%, and then raised back up a bit to 33% in the fall. And as you can see, this is really what we noticed for most of these variables that we're looking at here, where they were somewhat high before the pandemic. They dipped to lower rates kind of during that March to May period. And then we slowly see them start to raise again as students are back on campus and back in. So we see that students who reported any mental health concerns once they were back on campus reached 74%, and that was higher than it was before the pandemic. But students who reported drinking in the past 30 days took quite a big dip from 58% to 46%. So definitely a decrease in drinking during the pandemic. Again, this may be students who moved home and were living with parents or other family members and therefore weren't able to consume as much. But we do see as they return to campus and kind of get back in the swing of the school year, it does raise back up to 51%, although it's not as high as it was again before the pandemic. So I won't touch on, again, every data point here, and you will certainly get the slides after. I think I just saw that comment come through. So we'll definitely have time to delve into these more on an individual basis. But again, overall, we see that substance use, particularly cannabis use, prescription drug use, tobacco use, really decreased in that period of the initial pandemic compared to what it was before. So we also asked students to think about kind of a comparison point for themselves and their substance use as well as their stress. So these following 3 questions in the well-being survey asked report if they felt much more, a little more, the same, a little less, or much less either stress, cannabis, or alcohol use than before the pandemic. So we can see that 29% felt much more stress than previously while they were in the pandemic. But the majority, 42%, felt at least a little more stress. But we see some increases as well of students using cannabis much more and a little more than they were from March to May 2020 than previously, although the majority here, 34%, said they were really using the same amount. And we see as well 33% of students who say they consumed alcohol the same than before, compared to 28% using a little more and only 11% using much more. So all that being said, during the pandemic itself, again, from this March to May period, students didn't feel like their substance use or stress levels were changing too much more other than potentially some increases in stress. Next slide, please. And so kind of delving into that stress variable a bit more, since we did see it increase, we asked students to self-report the common sources of their stress. And again, this can be a select all that applies, so students can really highlight as many variables of stress as needed. But for these 4 on the left, these are ones that we saw the source of stress increase in the fall compared to either before that March 2020 period or before the March to May 2020 period. So for example, in the fall, when the survey went out, 85% of students cited academics or schoolwork as a source of stress, but this was only 72% in that period from March to May. So as students are back on campus, the stress from academics is increasing. They're experiencing more stress due to financial concerns compared to March to May. Mental health concerns increased from 35% to 43%. And then there's about 31% of students who cited missing the campus experiences. On the other hand, however, there were some sources of stress that we noticed actually decrease between kind of that peak pandemic period to the fall, such as future plans decreased slightly. Stress about the global pandemic decreased quite a bit from 53% kind of during that peak down to 44%. A bit of a reduction in stress due to reduced time with friends and a reduction in stress due to family. Again, thinking of potential living arrangements, if these students were living with family and then we're back on campus, there may be less stress associated with that. There may also be less stress, associated with family members getting sick or falling ill. So interesting to see kind of the ones that have increased once students were back on campus are all largely related to school, and the ones that were decreased are personal reasons. Next slide, please. So for our mental health concerns, we see somewhat similar patterns to the substance use data shown previously, where it typically was a bit, we have this landmark of before March 2020, and then it dips a little bit, and then it, in some cases, begins to rise back up in the fall. So for students who reported any mental health concern before March 2020, that was 70%. And it really dipped just slightly to 69% during that peak pandemic. But then as students came back to campus and started classes again, it really rose to 74%. So, 3 in 4 of our students were experiencing some form of mental health concern in fall 2020. Anxiety, we actually see steadily rise throughout these 3 time periods to the highest it had been previously in fall 2020. So definitely some anxiety as students are back in classes, back on campus. Chronic sleep issues stayed fairly consistent, although we did see it dip a bit in that period from March to May. Major depression actually has been on a downward swing since before March 2020, which is interesting, seeing its counterpart of anxiety increasing. And then here's where we kind of see those more typical results with panic attacks of being higher before March 2020 at 29%, to quite a big dip from March to May at only 19%. And then we see it slowly start to rise again for fall 2020. So looking more specifically at alcohol use now, which was a large part of our mock B survey, and we tried to match as many questions as we could into the well-being survey here for some counterpoints of data. So in terms of the students who reported drinking in the past 30 days, the average for all of our students was 58% before the pandemic. But again, here's where we see it really drop to 46% from that period from March to May. And then again, as students come back to campus, as they're back in school, back with friends, back living on campus, we see that drinking in the past 30 days rates start to increase again to 51%. So it's not quite back to where it was before the pandemic, but it's certainly rising kind of as things return back to normal at that time. And we see a much starker difference in that period before March 2020 to that pandemic period when we look at students under the age of 21. So before the pandemic, this was almost 1 in 2 underage students, and then it drops to nearly 1 in 5. So really thinking about kind of our underage students' access to alcohol specifically while they're on campus appears to be starkly different to their alcohol use while they were potentially under different living arrangements. And as we can see here, as they're back on campus, it starts to rise again to 38%. Very similar pattern here on the right. We're just looking at number of drinks on a night of drinking now. So again, we see that average at being at around 1.96 and 1.83 before the pandemic, but it really drops to just over 1 and just under 1 during the pandemic, and then it starts to rise again. So again, broadly, what we were seeing is students had this average or standard rate of drinking while they were in school. And then with the shift of the pandemic, moving to online classes, potentially moving home or to another living arrangement, substance use really kind of took a back burner. It was not as common, but as students got back into the pattern of campus and classes, it starts to rise to kind of meet that average that it once was. We also asked students related to alcohol kind of what their common drinking locations are. And again, this gives us a bit of insight into why that drinking rate may have decreased in the period from March to May 2020. So the only one to really take a huge increase during that peak pandemic time was where students who reported where they live. So again, if before the pandemic, students may have been more likely to say, for example, social gatherings or friends' houses, bars and restaurants. But in that period from March to May, we see the social gatherings and the bars and restaurants decrease and where I live increase. So as we all know, we were under stay-at-home orders. Bars and restaurants were potentially closed. Gathering with friends or family was not acceptable. So this where I live starts to increase. But in the fall, when students are back in that green, we see it start to decrease a bit as students regain that access to bars or restaurants or having social gatherings. We also see in this at-home parents or family residence wasn't an option in the MOCB 2020, but we kept it in for this well-being survey. We can see that, again, similar to where I live, about a third reported drinking at home, either their parents or family's residence. And that does take a bit of a decrease as students are back on campus in the fall. And we see the opposite for outdoor areas of bars or restaurants. Next slide, please. We also like to specifically highlight some data on underage drinking. Again, trying to kind of, we know our underage students drink, so we just want to understand better where they're drinking and potentially through that, how they are accessing their alcohol. So we see highlighted in red here, really the key takeaway is that while students were doing online classes or away from campus from March to May 2020, the percentage of underage students who reported their parents buying them alcohol really shot up to 21%. So this is almost double what it was before the pandemic. And again, once these students are back on campus, kind of back in the swing of the school year, this starts to decrease. So you may think there's not a ton of prevention strategies or things we can really do to impact the parents that are buying students their alcohol, but there's definitely still some messaging to be sent out and that we encourage our PIP contacts to do at the time of just, highlighting that these students are underage, that they do not have access to alcohol when they're back on campus, and that it may be setting an unfortunate precedent there. Really, our underage students who reported from an over 21 friend didn't change too much, although again, it dipped during kind of peak pandemic. Again, thinking about things like access to these over 21 friends may have been limited kind of in that period. And we see for where IDs were not checked or used a fake ID, that again, it dipped during the peak pandemic, but as classes resumed, it kind of raised back up to about where it was prior to the pandemic. So still an issue there of potentially targeting bars or restaurants in your campus communities, really highlighting the need for IDing. We offer a lot of statewide programs related to safe bars and IDing. So definitely check out some resources there if you're curious to learn more about that. Okay, turning now to cannabis use, we'll have a couple more substance use slides and then we'll go into our first break for questions. But 84% of students in the fall actually did not use cannabis at all. This is a pretty large increase from before March 2020 when it was only 71%. So we can see here that as students, again, moved home or off campus, they actually potentially stopped using and then did not restart using once they were back on campus. And we see that kind of in the data here as our students who use less than once a month decreased from 14% to just 3.9%. Students who used 1 to 2 times a month decreased from 4.2% to 2.4% and so on. What we do see though in kind of this red box is that for our students who used 1 to 2 times a week or more than 3 times a week, so these are really our frequent cannabis users, the pandemic and any changes to their living arrangement or lifestyle really did not impact their cannabis use here. It stayed fairly consistent among all 3 of these time periods. Again, just highlighting for our frequent cannabis users that that was still kind of a priority for them and something that was not going to be inhibited by the pandemic. Among these students who use less than once a month, though, or just 1 to 2 times a month are more infrequent users. Some of the common reasons that they cite using are because friends are using it, curiosity, they want to try it to experience it. And so again, if they're off campus, we can potentially assume that they maybe would not, again, be in situations where they see friends using it or have opportunities to try it or experience it. And that may be why we see them decrease in the March to May period. Similarly to alcohol use, we ask about common use locations for cannabis. And we see most of these, with the exception of prefer not to respond, actually decrease throughout these time periods. So the majority of students before March 2020, 68% were using at a social gathering or friend's house. So that dropped from about 2/3 to just 1/3 who are using at a social gathering or friend's house, either during the peak pandemic period or once they're back on campus. And again, these decreases can be associated to the fact that we saw that increase in the previous slide to students not using cannabis. But we see decreases for students using outdoors from 39% to just 24% in the fall, 57% down to 45% for where they live. Really large decrease, understandably, in students who report using in the residence hall or Greek house, assuming that, again, this was on campus and then they moved off campus. So we see that decrease to 1.3% and 1.3%, but we really don't see those continue to rise once they're back on campus. We'll look at some prescription drug data now. We asked 2 forms of prescription drug misuse on the MOCB. This focuses on just one form of misuse, which is prescription drug use without a doctor's prescription, but we also have data related to prescription drug misuse with a prescription, so using it in a manner other than prescribed. But specifically looking here at students who are using without a prescription, the only one we see a steady increase in, actually even from before March 2020, is the use of sleeping medications. So that actually somewhat steadily increased from before March 2020 to the fall 2020 to 1.7%. And my next slide will go into some more demographics there, but otherwise we see the same patterns here that we really saw with alcohol and cannabis use, which is that it was much higher before March 2020. and then really took a substantial dip for, as we can see, any prescription drugs, stimulants, a fairly slight dip for pain medications. And then as students returned to campus, returned to classes, that kind of started to rise again, but certainly not to, at least when this data was collected, to the extent that it was before the pandemic. Next slide, thank you. So again, looking at some further demographics of those students who reported using sleep medication. Again, the average was 1.7% among all the students, but it was higher reported among women. So 2% of women reported using sleep medication and 2.3% among students who identified as gender non-binary. It was also higher than the average for students who were sophomores and juniors, as well as students who were LGBTQAP versus heterosexual. So just interesting to take a look at this data a step further to really try and identify who these students who have maybe increased their use are. And that way we can help try and do some more specific targeting with our interventions. So we do this a lot with our other data as well, but certainly if you're ever interested in, again, who those students are who are using cannabis, even more specific, who the students are using cannabis in residence halls, we can always take a kind of deeper dive here to really do some targeted intervention. Related to prescription drugs, we also ask students to report how they obtain them. So similar to that question of stress earlier, we looked at a couple options that had increased after the pandemic and then a couple that had decreased. So the percentage of students who reported obtaining their prescription drugs by family members increased during the peak pandemic time and increased just slightly from 2.5% to 2.8% for students who reported they stole their prescription drugs. Kind of its counterpart here, we see a decrease in the students who say they purchased prescription drugs and a decrease in the percentage of students who say they were given prescription drugs by their friends from before March 2020 to during the peak pandemic. So again, this family relationship starts to make more of an emphasis here as we see that while students were either living at home or living in closer relationships with their family members, we see that they've had increased access to alcohol. They've been able to use cannabis where they reported living. And now with this data, they were also given prescription drugs by family members. One final slide here before our first break, wanted to look as well into our tobacco and nicotine product use. So we have this first graph at the top, which describes tobacco use at least once in the past year, and then we take a deeper dive into our daily users. But looking first at this at least once in the past year, again, very similar patterns here of high rates of any tobacco use product, e-cigs, vaporizers, or Juuls, or cigarettes, really all of these before March 2020. A fairly substantial dip in their use from March to May 2020. And then again, it slowly starts to increase in fall 2020 as students are back in school again. But again, it does not reach back to that original point where it was, whether it be because of the time of our survey, maybe we were just too early and these percentages did climb back up later in the semester, or potentially there were some shifts in substance use attitudes and behaviors among our students that just did not push these numbers back up to where they were. Among our daily users, however, and this is similar to what we saw with those frequent cannabis users, where the pandemic period or that March to May 2020 really did not affect their use all that much. If anything, among our e-cigarette and vaporizer users, it actually increased a bit from 4% to 4.5% and then 4.6%. Juuls did decrease a bit, although it stayed consistent from March to May to fall. And then just really slight decreases here among our cigarette users. We see the same thing here with smokeless tobacco, where that stayed fairly consistent as well. So our daily tobacco and cannabis users not seeing as much shift there as compared to our students who are using tobacco or nicotine less frequently. Okay, so I'll take a quick break there just to see if there are any questions, if anyone wants me to go back to any of those substance use slides. And then this next section will talk a bit more about mental health, retention, and stress. But any immediate questions or thoughts anyone would like to share? All right, if not, I can move along then. Again, feel free if you have any questions, kind of as we're on a slide, feel free to take yourself off mute or pop anything in the chat there, and we can address it right then. All right, so again, moving on to some deeper data into mental health specifically, but still tying in some substance use data here. So kind of as we saw, a large percentage, 76% of our students lived with parents or other family members in that peak pandemic time from March to May 2020. So if we look at these students who, comparing those who lived with those parents or family compared to students who had an other living arrangement, we wanted to see if there were any noticeable differences here in their mental health and their substance use. So we actually see that among students who were in an other living arrangement, they had slightly higher stress levels, at least in the past 2 weeks, compared to students who lived with family. And again, this is among our students who reported their stress was overwhelmed or unbearable. So this is, again, these students are really feeling the max amount of stress and pressure. Similarly, students of an other living arrangement reported a higher rate of any mental health concerns. They were also reported drinking at much higher rates than individuals living with parents or other family members, higher rates of cannabis use, prescription drug misuse, and tobacco nicotine use. So a couple notes here, all of these have this little asterisk next to them. So all of these are statistically significant differences with a p-value less than 0.01. So while some of these differences may look, not that far apart from one another, this stress, for example, 29 to 33%, we were able to confirm that this was statistically significant. So we do see some very worthwhile differences here, and it does appear that living with these parents or other family members really was a protective factor for some of these substance use and mental health variables during that peak pandemic time. We were also curious into looking at attitudes towards transfer and retention and well-being during this period, specifically looking into some breakdown of racial categories. As we all remember, during this peak pandemic time, we were also experiencing kind of a dual pandemic of violence and injustice against communities of color. Margot will talk about this more in her presentation, but we really wanted to give light to that movement and see if our data showed any of that impact more so among our students of color compared to our white students. So looking here, since March 2020, we asked how many students thought of transferring or quitting due to a financial concern. So the average among all of our students was about 12%, but it was highest among our Hispanic, Latino, and Black African American students, as well as our biracial students. So they were experiencing higher rates of thinking of transferring or quitting specifically due to a financial concern. We see similar differences here in terms of feeling stressed due to financial concerns. So not necessarily related to retention, but just general stress. And again, the average was about 61%, but that was felt at a higher rate among our Black African American, Hispanic, Latino, and biracial, multiracial students. Although all of these are still fairly in line with the average, where we really start to see it break off is reports of feeling stressed due to social unrest related to racial injustice. So the statewide or sample average was about 20%, 1 in 5 students, but this was felt and endorsed much more heavily among our biracial, multiracial students and our Black African American students. And so again, we like to highlight some of these areas more just to lend light to the view of using an intersectional lens when working and discussing these issues with your students. So while the pandemic was obviously going on and our students were impacted by it, just thinking about these specific students who are kind of dually impacted by this other social unrest, racial injustice that's going on as well, and just holding those kind of together and making sure both of them are being addressed in conversations and as things that have impacted our students. Similarly, with this last point, we wanted to see which students had experienced a mental health concern, but did not seek assistance. So largely this was our Black African American students, again, our Hispanic Latino, and our multiracial biracial students. So they're experiencing these thoughts of transferring, feelings of stress at higher rates than their peers, but they're also at higher rates than their peers not seeking assistance for those. And so to kind of delve into further, are they not utilizing assistance, seeking assistance because they have simply not heard of the resources provided? That doesn't seem to be the case. So from March to May 2020, just over half, 53 of these students had at least heard of the wellbeing resources that their campus was providing, whether it was in person or virtual. And this was actually reported at higher rates among our Asian students, and it was about on par for our Hispanic, Latino, and biracial students, slightly lower among our Black African American students. But we do see among the students who say they actually utilize these resources that it was higher among our Black African American students, in our Asian students, in our biracial, multiracial students. So this is actually a point of good news here, is that, again, although these students are experiencing higher rates of stress, whether it's due to financial concerns or the racial justice movement that was happening at the time, they're still about on par with their students of hearing the resources that are being put out and then actually accessing those resources. So again, a point of good news here to see that those resources are reaching the intended populations. We also wanted to see if these differences in folks who heard of the wellbeing resources and actually utilized them was had any differences based on living arrangement. Again, thinking about if these students were still on campus or in the city of their college or university, whether that had an impact on being able to recognize these services compared to students who maybe left the state altogether. So again, from this March to May 2020 period, not too much difference in terms of hearing of health and wellbeing resources, with the exception of students who reported living in an on-campus residence hall, definitely had an increased rate of hearing or being aware of these resources, which is not too surprising if you're on the campus that they're being promoted at. And they were also the ones, looking in the graph on the right, to actually utilize those health and wellbeing resources more. So the other breakdowns of kind of living arrangements are fairly consistent with the average and with one another. But we do see that, again, being on campus, specifically in a residence hall, did have an impact on who was made aware of some of these resources that were being put out at the time. And so these last couple slides here, as I mentioned earlier, we had added some questions related to student safety in this wellbeing survey. Again, trying to tap into if our students, as they were removed from campus in that peak pandemic period and potentially made to live in different living arrangements, if there is really any indication or experiences of being unsafe during that time, whether it was physically, psychologically, if there was pressure or threats. And then we also included a question related to access of medications such as birth control and or antiretroviral therapy. So if we look at this first set of graphs, so among the students who felt physically and or psychologically, mentally unsafe with the person they resided with, the average was about 5.4%. but this is over double among our LGBTQAP students and almost 4 times among our gender non-binary students. So we really see here that the campus environment and where they were living while in school was certainly a potential protective factor for these students in terms of feeling physically and or mentally unsafe. And that transition to whether it was off-campus housing, back with friends or family, really potentially impacted their physical and mental safety. We see similar discrepancies when we look at the students who were feeling pressured, threatened, or forced to do something. There's a slightly higher average here of 11%, but it's again higher among our LGBTQAP and gender non-binary students. And I apologize, I should have clarified sooner. LGBTQAP stands for lesbian, gay, bisexual, queer, questioning, asexual, and pansexual. And finally, with being unable to access other medication, these were kind of the smallest percentages of our students, but LGBTQAP and gender non-binary students still experienced that impact of safety at higher rates than their counterparts in the overall average of students included in the sample. So we also wanted to see if these impacts of safety also had an impact on stress. So again, looking kind of at the key here, the individuals who fall in pink for high stress level, these are students who reported that their stress was overwhelming or unbearable. And our students who fall into the category of low stress levels in blue are students who reported their stress as being minimal or a little stressed but managing. And so the takeaway here we can really see is that from March to May, that peak pandemic period, again, students who reported feeling unsafe, kind of in the second graph, feeling pressured, threatened, or forced to do something in the third graph, and then being unable to access medication, those students were more likely to experience high stress levels compared to students who were not feeling those impacts of safety. So just to highlight here again, those feelings of safety or lack thereof were also compounded by high feelings of stress among our students. And we are aware that as students are stressed and experiencing those impacts of safety, this may lead to increased rates of substance use or other coping mechanisms, or potentially, as we hope, increased rates of seeking resources on campus or wanting those campus resources. And so in our last couple of slides here, again, some of this data you may feel is a bit outdated as of now, as it's kind of, again, taking a pulse of how our students were feeling regarding COVID-19 at the time of this survey. But I think still helpful to see kind of how students were feeling as they come back on campus, especially as our students are returning again from this most recent winter break, as we're kind of still in the throes of this pandemic. So when we think specifically of how students responded to their campus resources and prevention efforts, 28% strongly agreed and 45% agreed that they knew where to go to find the most updated information about their school's COVID-19 policies. So just over 3/4 there, the majority of students are confident that they know where to go. A little bit smaller percentage, though, 19% strongly agree and 33% agree that they were confident in the campus administration COVID prevention efforts. So while they potentially knew where to go to find info, they were a little less confident in kind of what their university or school was doing at the time related to COVID. Similarly, we also wanted to take a pulse of how students were feeling towards social gatherings. So 11% felt that any type of social gathering was safe. Again, the survey was put out during fall 2020, so we were still very much in the throes of the pandemic. 17% felt that a social gathering was safe if people were 6 feet apart and or wore masks, but this was regardless of a number of people who were there. 44%, almost all these students felt that a social gathering was safe if less than 10 people were in the room and everyone was 6 feet apart and or wears masks. And then we see a couple other percentages there for safe if less than 10 people, regardless of 6 feet apart, wearing masks. Just 11% felt that it was unsafe to have any type of social gathering at all. And then 3.2% prefer not to respond. So really just want to highlight this again. Again, as students are returning back to campus, there are multiple different feelings towards social gatherings and kind of their safety, really regardless of what CDC or campus specific mandates may have in place. We also wanted to get a sense of what individual prevention strategies students were using to prevent COVID-19. And these are students who reported either always or very often doing the following strategies. So the majority were always wearing a face mask or covering in public at 74%, monitoring their own health at 65%. A little less, 43 and 40, always following guidance from the CDC or keeping 6 feet social distance in public. But for the most part, this was always at least over half of our students were following these mitigation strategies. Again, these numbers could look quite different now, but important to see at least kind of in the peak part of the pandemic when we were first experiencing students coming back to campus, what the majority were doing. And finally, again, you know, depending on where you're at, if there's a mask ordinance still in place or not, we did find at the time that students were wearing face masks or covering less frequently if their campus was in a city or county with no mask ordinance. So really seeing that community environment related to a mask ordinance was positively influencing the number of students wearing masks. All right, so I'll take another quick break here to see if there are any questions or thoughts before showing a couple of those campus-specific strategies with this data. So any thoughts or questions? All right, we will just keep chugging along then. So finally, to wrap us up here again, I wanted to show some actual concrete examples of how a couple of our PIPCon campuses utilize the results of this survey kind of in real time, but also potentially how yourselves or your campuses could continue to utilize data like this, even though, again, we are in 2022 now and kind of experiencing a different version of the pandemic. So firstly, we have UCM. So when they got the results, this is University of Central Missouri. When they got the results from the well-being survey, they shared it with their COVID leadership team, and at their campus, this included a lot of different stakeholders, such as the VP and AVP of student experience. They shared it with marketing and community relations leaders, their budget manager, just really a diverse group here, as Joan mentioned earlier. This is extremely helpful when we think of prevention as being a shared responsibility and having multiple input and potential for implementing prevention strategies. So they really did a great job of including multiple roles and backgrounds in this presentation. And so for that, they created the presentation, shared it with their coalition as well. They compared it to their spring 2020 and fall 2020 data, again, to see what was changing from before the pandemic to now among their surveys or among their students, excuse me. And they really use that qualitative data. So I didn't touch on any of that in these slides, but we did have a lot of open-ended questions for students to give feedback to, whether it was what their sources of stress were, how they felt their campus was responding to the pandemic. So they really took the time to go through that and get that feedback from their students. And then they also, just as a fairly low-hanging fruit, just increase the mental health content on their social media due to some of the results they saw. Another one of our campuses, Missouri S&T, created some social norms messages from this data, which you can see below here. So again, a fairly low-hanging fruit. I believe these were posted just periodically on their social media pages, but posting things like, did you know 93% of S&T students wear a face covering while in public? they really highlighted those individual mitigation strategies that their students were implementing and that they saw in the survey to really promote that to the rest of their students and ensure that even if they didn't have a mask mandate when students came back, or they didn't have all of these prevention methods kind of mandated, that their students still cared about these aspects of safety and wanted to continue them while on campus. Next slide, please. Thanks. And so our third example here is the University of Missouri. And so again, we had a lot of qualitative open-ended questions on our survey. And we noticed that with our University of Missouri students who participated specifically, they really had a lot to say and a lot to tell us. So, and which we're happy to hear. So we really compiled and gathered that data into an analysis report for them. But they took it one step further and presented that to their Department of Strategic Initiatives and Assessments, and really gave them a nice overview of the summaries of themes that emerged, and shared it further with their administration and leadership team, the Mizzou Care team, again, really getting it out in front of multiple sets of eyes and perspectives, so that multiple kind of prevention strategies could be initiated and put in place. So that is all my slides. Again, I know it was very data heavy and went through very quickly. So I am happy to go back on anything, or again, I'm sure these slides will be shared in the future for you to delve into a bit more on your own. But while we still have some time here, would love to hear anyone's general reactions or thoughts about the data. I think we talked a lot about some troubling points in the data oftentimes, but I'd also love to hear what potentially some of the good news is that you noted, especially if you can kind of assume that it's still happening on your campus now, or if you've seen these kind of upward trends continue in your work. And then would just be curious to hear if anything presented here might impact your work moving forward. So I'll open it up to you all for any thoughts or questions, but thank you so much for being here. I'll pop my email in the chat if anyone has any questions, but thank you.
So please feel free to put any questions in the chat for Kaylee while we are transitioning to Margot's portion of the presentation today. This is a time for you to come off mute and ask questions in the chat. But we will probably roll right into our next presentation if possible, just to save you all time. I'm not seeing any questions come through at this point. But I just want to make a note as we transition. So part of what we will be talking about over these next couple of days is really leaning into the data and learning what we can from the experience of the pandemic to push us forward as we take on our work in AOD prevention moving forward. I think I have folks that we work with all the time that I think expect to be looking at data from 2019 post-pandemic, and it will be the same. And I think our students are forever changed. Plus, they're not the same students. These are students that have been in the pandemic for quite a while. By the time we can truly get to a place where we say we are past the pandemic or past the continual effect it has on our lives. And so one of the ways in which we do that is to take a little bit of a deeper dive into really the dual pandemics that our students were experiencing, as Kaylee noted in her last set of slides. And so we're going to talk a little bit about the social determinants of health in the context of prevention. And this will inform us as we continue to talk on Friday about leading with data and leading with a lens of cultural humility. So Margot, I'll turn things over to you.
Hi all, really excited to be talking to you all today. I am going to stay off video. I apologize, but I typically have internet troubles. So just to keep things moving, I'm going to stay off video, but Joan set that stage really well. I'm really excited I'll share some more data actually from our 2020 survey. So I know this seems a little odd that we're again looking backwards to look forward, but we'll get into that a little bit. And then again, just really talking about the social determinants of health and kind of building off some of the things that Kaylee mentioned. And again, these dual pandemics, so not just COVID-19, but the pandemic of social injustices, specifically racial injustice, and again, some of the impacts of these social determinants of health on health equity. So really quickly, I do just want to do a land acknowledgement and just note that we are gathered on the unceded land of Native peoples. I ask you to join me in acknowledging these communities, their elders, both past and present, as well as future generations, and to just acknowledge that the spaces that we occupy were founded upon the exclusion and erasure of Indigenous peoples, including those on whose land our institutions are located. So this acknowledgement just demonstrates a commitment to beginning the process of working to dismantle the ongoing legacies of settler colonialism. So I'm located in St. Louis, Missouri, which is on Kickapoo, Kaskaskia, Miami, Ochete-Shakowin, and Osage land. So again, we're going to really delve into some of these social determinants of health, what they are, how they impact or are impacted by health inequities. And then again, kind of, I hate to say post-pandemic, right? We're still kind of in the thick of it, but thinking specifically about how that might impact our alcohol and other drug work, as well as our health and well-being work. So I'll actually focus more on that within our data. That was kind of the lens we wanted to take in looking at this data, but moving forward, thinking about how we can tailor it to use a little bit more of an equitable approach. So I know Joan shared in her early slides the strategic prevention framework. And again, I'm really focusing sort of in this upper third quadrant, looking at some assessment data, and then really thinking about that cultural competence, cultural humility piece, and then hopefully giving you some thoughts about building capacity going forward. So like Kaylee mentioned, we saw those substance use rates decrease during those campus closures, but increase and, then not quite return to those same rates. Again, a pandemic did not mitigate our students' substance use behaviors. And we also saw those mental health concerns rise and increase. I think our 2021 data really saw all of this sort of go back to the way it was or even higher. I think our mental health concern rates continued to go up. So, given what we've seen, kind of what does this mean for our work? I know you all probably been pondering that as Kaylee shared this data, and feel free to put in the chat. But I think at least what this says to me, which is sort of tough, right, is that we need to keep the main thing the main thing. We have to keep doing this alcohol and other drug prevention work. We have to sort of recenter ourselves, in promoting the health and well-being of students, but that is very difficult. And I want to acknowledge that I know a lot of this work has transitioned. I know that a lot of you as prevention professionals have been tasked with COVID mitigation. You've been asked to do more with fewer resources, and that we are all collectively experiencing the trauma of a global pandemic that is continuing. And so I know it's sort of tough to say, oh, this means we have to go back, to doing the things that we know are important, and it does. But I think now more than ever is the time, right, to think about how we can restructure and reframe our work to make it more equitable, accessible, and really dive into what the needs of our students are and how we can structure and tailor our work to those who are underserved. So before we talk about the social determinants of health, I want to talk a little bit about health disparities and health inequities. Sometimes these are used really interchangeably, but I want to be intentional and not do that here. A health disparity really refers to a higher burden of illness, injury, disease, disability, mortality, et cetera, by one group relative to another. And that really just states that there's a difference, right? It doesn't delve into kind of why that might exist. So for example, overall, we see higher rates of heart disease, high blood pressure, diabetes, and stroke among Black or African-American patients in the US compared to white patients. And that's straight from the US Department of Health and Human Services Office of Minority Health. But if we, again, delve a little bit further and think about those health inequities and why that disparity exists, were built and currently function that cause those differences. So health inequities are typically those systemic and avoidable or preventable, unjust and or unfair conditions that create those differences, those disparities, right? So they exist for a variety of reasons, but it is not typically just individual choice or individual behavior. It's really linked to these social determinants of health that we'll talk about on the next slide. And often, right, these are tied to the health inequities like structural and systemic racism and sexism, right? And so that is a big portion of why we see these differences, right? So it's related to those social and economic policies and practices that create barriers. All right, so these are the social determinants of health. So how are our health and well-being impacted by these things? So overall, the social determinants of health are the conditions and the places where we live, work, learn, and play that again affect a lot of our health. So health and healthcare, I think, is typically the most natural, connection for folks. That connection between people's access to and understanding of health services and their own health. So for our college students, they come to us having experienced the healthcare system in some way, I'm sure, but that might look like their family's ability to access healthcare, to afford healthcare. It even could mean their health literacy skills. So their ability to not only understand health information that's put in front of them, but also to navigate our healthcare system. Do they know how to make doctor's appointments? Do they know how to advocate for themselves and for the care that they need to receive? What kind of provider linguistic and cultural competency have they had access to? Have they been able to see providers who either understand or who match their identities and are able to provide good quality care for them? Moving on to economic stability, right? So that connection between financial resources. So for our students, potentially their family's income or socioeconomic status, what the cost of living is like wherever they are from. Could be their employment or their family's, typical employment, food and housing security, debt, even if we think about that. And I know, the cost of college is rising and students are having to take on more debt as a result of entering higher education. But then also educational attainment is a big piece of the social determinants of health and how that connects. So just the fact that students have come to our institutions of higher education, think about their early childhood development, where they went to high school, what type of services were available there. If they, their language and literacy skills, their problem solving skills, any other type of vocational training that they might have, all really pieces of that educational context. And then the social and community context, really that connection between the environments, but the community environments of where we exist. So things like civic participation or community engagement, social cohesion and positive family involvement, conditions in the workplace potentially, conditions in the community, neighborhood, et cetera. But also things like discrimination and racism and sexism, et cetera, play into this piece of the social determinants of health as well. And then finally, neighborhood and the built environment. So that connection where someone physically lives, so the housing, the neighborhood, things like housing quality, transportation, access to transportation, availability of healthy foods, air and water quality and pollution, crime and violence, but even things like access to green space and playgrounds, et cetera. So the other point really to make here, right, is that these things, someone's neighborhood and the built environment is going to be affected by, what they can afford. And in their neighborhood, what type of health and healthcare is accessible to them? What type of educational attainment can someone get based on their economic stability, right? So all of these things are really play into each other. And when we look a little bit further, right, a lot of these things have been predetermined in a lot of ways by historic policies and practices and things that are continuing to influence the health of folks today. So I also just want to briefly mention the socio-ecological model. I think this is a frame that a lot of people are familiar with, and that might help sort of contextualize the social determinants of health, right? Or we map the social determinants of health onto the socio-ecological model. But again, just thinking about on an individual level and with individual factors, people have, right, their personal, physical, and mental health. That they have their knowledge, they have their social, emotional learning skills, et cetera, but that those are, influenced, impacted, right, again, by that social and community context, the interpersonal relationships that they have, by their community and the, resources that they have access to. And then again, on a societal level, what laws, policies, practices, and again, historic laws, policies, and practices that impact health in general. Okay, so I do have a quick video. I know this is kind of basic, and I think I'm actually going to stop sharing and then read, because I think I forgot to share my audio. Okay, there we go. All right, so let's believe this works. Somebody please chat me if it does not. Okay.
Brutal killing of George Floyd triggered a national reckoning with racism unlike anything we've seen since the 60s. And it sparked new conversations about systemic racism and how we all need to be fighting to end it. Black racism was born 400 years ago when 12 million Africans were dehumanized and sold into slavery, and then continued with the terrorism of lynchings, the Tulsa Race Massacre, and Jim Crow segregation. And although the civil rights movement changed history by fighting for equality and justice, systemic racism, the kind that infiltrates institutions like banks, schools, and the law, is much more insidious. Let's look back and see how systemic racism became embedded in American society. Back in the 1930s, when Social Security was introduced, it excluded domestic and agricultural workers, and they accounted for 2/3 of Black Americans. This inequality forced many older Black Americans into poverty and homelessness. Between 1934 and 1962, the Federal Housing Authority underwrote $120 billion of home mortgages, and 98% of them went to white people. Federal policy said that Black neighborhoods were a bad risk and therefore not eligible for loans. Even the GI Bill excluded Black veterans from its beneficial housing provisions. Since then, house values have risen dramatically, giving white homeowners a huge bump in wealth from which Black people were excluded. Redlining was the system used by banks to determine which neighborhoods would get loans to buy homes. Black neighborhoods, outlined in red ink, were deemed the riskiest to invest in. Redlining made it impossible for Black people to get loans. Redlined areas also didn't have the tax base to fund good schools, healthcare systems, or transportation, causing safety concerns and subsequent over-policing, which seeded the problems we see today. Even now, predominantly white schools receive more than $20 billion more funding than districts that serve mostly students of color. And today, Black home ownership is at an all-time low, only 42% compared to 72% for whites. This generational history matters when we talk about the wealth gap, because inheritances are very significant to current wealth, and family wealth takes generations to build. In the U.S., white families hold 90% of the national wealth, Latino families hold 2.3%, and Black families hold 2.6%. Racial pay inequities widen the gap. This year, the average white worker made 30% more than the typical Black worker. With the whole family's income, Black households earn 60% of the average white household. Lower incomes mean that the poverty rate for Black families is over twice that of white families. Black individuals are also twice as likely to be unemployed than white individuals. And even though the number of Black college graduates is growing, they're twice as likely to be unemployed as all other graduates. One U.S. study found that job resumes with traditionally white-sounding names received 50% more callbacks than those with traditionally Black names. African Americans are still incarcerated at more than 5 times the rate of whites, even though imprisonment rates have fallen in the past few years. Black inmates make up over 30% of prisons, yet only 12% of the country's population. And even though African Americans and whites use drugs at similar rates, the imprisonment rate of African Americans for drug charges is almost 6 times that of whites. Black Americans are more likely than white Americans to be arrested, and once arrested, they are more likely to be convicted, and once convicted, they are more likely to get lengthy prison sentences. Let's look at police stops. The Stanford University study analyzed more than 100 million traffic stops across America and found Black drivers are 20% more likely to be pulled over and more likely to be searched. In fact, in New York City, 88% of police stops in 2018 involved Black and Latino people, while 10% involved white people. Of those stops, 70% were completely innocent. A crisis like COVID highlights the inequalities in the society. Black people are dying of COVID at 3 times the rate of white people because of higher rates of underlying health conditions, higher density poor neighborhoods, more employed as frontline workers, and poorer access to testing and healthcare. So that's systemic racism. This awakening to injustice is our chance to make it right. Listen, learn, and act now.
All right, so again, no, that's a pretty basic video, and I see somebody in the chat asking about this, and yes, I will definitely post that and find the link to that and share it as well. But again, I think that, again, sort of wraps up what we've been talking about, and then sort of as we move forward, really, again, highlighting in these dual pandemics, systemic and structural inequalities create these health inequities, right? And they are public health concerns, right? We're seeing increasing evidence, right, that folks are impacted disproportionately by COVID-19. I've heard people say, oh, we're all in the same pandemic. And that might be true, but we are not all experiencing it in the same way. And we know that all of these other things that are sort of behind the scenes are really contributing to these different experiences. And we need a deeper understanding of the societal factors that impact health and well-being. And that's why I think the social determinant of health work is so important, because we can look at those 5 factors, but when we really delve into why those things are different for different folks, it really paints that picture of this systemic and past, history that is leaving this legacy where there are inequities. Right, so what can we do to really not perpetuate this? We need to, when we make decisions as we're at our institutions, sometimes we are doing this without accounting for, or sometimes flat out in the face of, but we need to think about how they might benefit one population over another, and recognize when the cultural knowledge, history, and locally generated approaches of folks are excluded. All right, so there's that normalization of historical, cultural, institutional, and interpersonal dynamics that routinely advantage white people while producing cumulative and chronic adverse outcomes for people of color, Black and Indigenous people of color specifically. Right, so when this happens, programs and policies can reinforce or compound those existing, specifically race-based inequities. And this was from Advancing Health Equity in Minnesota, but I really liked, this is a document they have all about essentially racism as a public health crisis. Right, so I think we need to reapproach this work with an equity lens. And I know Joan is going to talk more about the strategic prevention framework on Thursday, but really, again, building in that cultural humility piece into the work that we do, and analyze and diagnose the impact that our policies, practices, programs, et cetera, have on underserved, marginalized folks, to identify and potentially eliminate those barriers, right? So prevention as a part of this, we don't have excuses any longer to address this. And I know personally, and I think for all of us, these were conversations we were having more back in 2020, and things have changed a little bit, and we are having these conversations less. But we need to always be thinking about these things and continuing this work, with the ultimate goal being justice, right? So I'm sure many of you have seen this image or something similar to this image, really highlighting the differences between equality, equity, and justice. But equality, when we give everyone the exact same thing, regardless of what they need. And equality doesn't get us right to a better place necessarily. Equity being where we're really focusing more on the needs of people based on what they have and what would help make things better. And equity is certainly great to strive for. But the ultimate goal, right, is justice, where we are changing the environment, where we are breaking down the barriers and challenges overall to fix the structures that uphold those unequal and inequitable processes, right? So to achieve health equity, we have to be thinking about changing these systems. I think there's a very timely example of this. If we think about just recently, the fact that for COVID tests per home have been a way to distribute COVID tests. But it is not equitable, right? That certainly folks who are in multi-generational households, individuals who live with roommates, folks who live in apartment buildings potentially that have, one singular address, that's not going to be an equitable way to distribute tests. So if we were moving towards equity, it might be, a certain number of tests per person who lives at each address, and that might be a better way to distribute things equitably. But if we were moving towards true justice, we would additionally be considering folks who don't have a home address, folks who are unhoused, people who don't have regular access to Wi-Fi and internet services to be able to request the tests. So really moving again towards unlimited as needed testing to all folks, both rapid self-administered tests and better, more equitable in-person testing services without insurance, all of those things. So just an example. And so then I also want to talk a little bit about intersectionality. So this concept or term coined by the scholar, writer, and activist Kimberly Crenshaw, really a theory for understanding the ways that these interlocking systems of power create unique forms of oppression and harm on individuals with various intersecting identities, right? So I really like this image. And again, there are many more that are not pictured, but I think this is just such a key thing that maybe we've all heard more frequently or been talking about a little bit more frequently. But I do want to play a little bit of a TED Talk of Kimberly Crenshaw's that I think is just really fabulous to sort of set up this next piece. So hopefully the video is showing. Nope, it does not look like it is. Hold on.
It was.
Stop. It was. Oh.
Yeah.
Okay.
I'd like to try something new. Those of you who are able, please stand up. Okay, so I'm gonna name some names. When you hear a name that you don't recognize, you can't tell me anything about them, I'd like you to take a seat and stay seated. The last person standing, we're gonna see what they know, okay? All right. Eric Garner. Mike Brown. Tamir Rice. Freddie Gray. So those of you who are still standing, I'd like you to turn around and take a look. I'd say half to most of the people are still standing. So let's continue. Michelle Cusseau. Tanisha Anderson. Ara Russer. Megan Hockaday. So if we look around again, there are about 4 people still standing. And actually, I'm not going to put you on the spot. I just say that to encourage transparency, so you can be seated. So those of you who recognize the first group of names know that these were African Americans who've been killed by the police over the last 2.5 years. What you may not know is that the other list is also African Americans who have been killed within the last 2 years. Only one thing distinguishes the names that you know from the names that you don't know: gender. So let me first let you know that there's nothing at all distinct about this audience that explains the pattern of recognition that we've just seen. I've done this exercise dozens of times around the country. I've done it to women's rights organizations. I've done it with civil rights groups. I've done it with professors. I've done it with students. I've done it with psychologists. I've done it with sociologists. I've done it even with progressive members of Congress. And everywhere, the awareness of the level of police violence that Black women experience is exceedingly low. Now, it is surprising, isn't it, that this would be the case? I mean, there are two issues involved here. There's police violence against African Americans, and there's violence against women, two issues that have been talked about a lot lately. But when we think about who is implicated by these problems, when we think about who's victimized by these problems, the names of these Black women never come to mind. Now, communications experts tell us that when facts do not fit with the available frames, people have a difficult time incorporating new facts into their way of thinking about a problem. These women's names have slipped through our consciousness because there are no frames for us to see them, no frames for us to remember them, no frames for us to hold them. As a consequence, reporters don't lead with them, policymakers don't think about them, and politicians aren't encouraged or demanded that they speak to them. Now, you might ask, well, why does a frame matter? I mean, after all, an issue that affects Black people and an issue that affects women, wouldn't that necessarily include Black people who are women and women who are Black people? Well, the simple answer is that this is a trickle-down approach to social justice, and many times it just doesn't work. Without frames that allow us to see how social problems impact all the members of a targeted group, many will fall through the cracks of our movements, left to suffer in virtual isolation. But it doesn't have to be this way. Many years ago, I began to use the term intersectionality to deal with the fact that many of our social justice problems like racism and sexism are often overlapping, creating multiple levels of social injustice. Now, the experience that gave rise to intersectionality was my chance encounter with a woman named Emma DeGraffenreid. Emma DeGraffenreid was an African-American woman, a working wife, and a mother. I actually read about Emma's story from the pages of a legal opinion written by a judge who had dismissed Emma's claim of race and gender discrimination against a local car manufacturing plant. Emma, like so many African-American women, sought better employment for her family and for others. She wanted to create a better life for her children and for her family. But she applied for a job and she was not hired, and she believed that she was not hired because she was a Black woman. Now, the judge in question dismissed Emma's suit. And the argument for dismissing the suit was that the employer did hire African Americans and the employer hired women. The real problem, though, that the judge was not willing to acknowledge was what Emma was actually trying to say, that the African Americans that were hired, usually for industrial jobs, maintenance jobs, were all men. And the women that were hired, usually for secretarial or front office work, were all white. Only if the court was able to see how these policies came together would he be able to see the double discrimination that Emma DeGraffenreid was facing. But the court refused to allow Emma to put two causes of action together to tell her story because he believed that by allowing her to do that, she would be able to have preferential treatment. She'd have an advantage by being able to have two swings at the bat when African American men and white women only had one swing at the bat. But of course, neither African American men or white women needed to combine a race and gender discrimination claim to tell the story of the discrimination they were experiencing. Why wasn't the real unfairness law's refusal to protect African American women simply because their experiences weren't exactly the same as white women and African American men? Rather than broadening the frame to include African American women, the court simply tossed their case completely out of court. Now, as a student of anti-discrimination law, as a feminist, as an anti-racist, I was struck by this case. It felt to me like injustice squared. So first of all, Black women weren't allowed to work at the plant. Second of all, the court doubled down on this exclusion by making it legally inconsequential. And to boot, there was no name for this problem. And we all know that where there's no name for a problem, you can't see a problem. And when you can't see a problem, you pretty much can't solve it. Many years later, I'd come to recognize that the problem that Emma was facing was a framing problem. The frame that the court was using to see gender discrimination or to see race discrimination was partial, and it was distorting. For me, the challenge that I faced was trying to figure out whether there was an alternative narrative, a prism that would allow us to see Emma's dilemma, a prism that would allow us to rescue her from the cracks in the law, that would allow judges to see her story. So it occurred to me, maybe a simple analogy to an intersection might allow judges to better see Emma's dilemma. So if we think about this intersection, the roads to the intersection would be the way that the workforce was structured by race and by gender. And then the traffic in those roads would be the hiring policies and the other practices that ran through those roads. Now, because Emma was both Black and female, she was positioned precisely where those roads overlapped, experiencing the simultaneous impact of the company's gender and race traffic. The law was like that ambulance that shows up and is ready to treat Emma only if it can be shown that she was harmed on the race road or on the gender road, but not where those roads intersected. So what do you call being impacted by multiple forces and then abandoned to fend for yourself? Intersectionality seemed to do it for me.
So there's more to this video. I can share this link as well, but I like that. I think that court case is such an incredible example of what happens when we fail to recognize intersectionality, when we are failing to consider how these things interlock and impact folks. And so moving a little bit sort of into this piece about cultural competence and cultural humility, right? We're talking about changing large systemic things, which is very difficult. But I think it does start a little bit internally. And so cultural competence, really that concept, the acceptance and respect for culture that's consistently demonstrated in policies, structures, practices, and attitudes, et cetera. But again, I think delving even a little bit further into cultural humility, that humble and respectful attitude towards individuals of other cultures that pushes ourselves, right, to challenge our own biases, recognize that we can't possibly know everything, and approach learning about other cultures as a lifelong process, right? So we never want to say that we are, culturally humble or culturally competent. We can't ever be culturally competent or humble, but we can practice cultural competence or humility and apply that framework to our work, right? So we have to, again, examine and identify our own implicit biases. We have to recognize that the society that we have grown up and been socialized into for most of us is, in the US, that it is impacted again by all the things that we've been talking about. So we have to do active daily work to unlearn thoughts, patterns of behavior, et cetera. So when we are doing this work sort of with more of an equity and cultural humility lens, right, we're appreciating diversity where we're able to function effectively and work, sort of with folks with different backgrounds, again, always recognizing that intersectionality piece and continuously considering those things when planning and implementing prevention strategies. And when we say culture too, we aren't just talking about race and ethnicity, it goes beyond that, but that is where a lot of this is centered and framed. All right, so now I am going to get into some data as well and really look at the impact of the social determinants of health, some proxy measures that we have in our survey. We don't ask specific questions about the social determinants of health, but to really look at kind of what those existing impacts are on students. Like I said, we are actually looking at 2020 data, which was implemented prior to campus disruptions due to COVID. Again, sort of to stay in line with kind of what the data that Kaylee was looking at, and to really see, again, what like the sole impact of the social determinants of health are, honestly, without that COVID impact yet. And we did also see, these are some of the really proxy measures that we're looking at. In our 2021 data, we did see that the demographic makeup of campuses changed a little bit, and that we saw actually a lower percentage of first generation college students and Pell Grant eligible students, and students experiencing food insecurity. And I think we would kind of think that that is likely because those students weren't able to attend or return to campus as a result of the pandemic. So we are going to look at those three and then delve a little bit into some data on race and ethnicity as well. All right, so related to first generation, we see that 27% of our Missouri college students identified that they were the first generation in their immediate family to attend college. And then about 34% were eligible to receive a Pell Grant. So for those unfamiliar, that's a federal financial aid that's usually awarded only to undergraduate students who have exceptional financial need. So we're looking at these two things really as kind of a proxy for, economic stability, as well as educational attainment, right? Even though those aren't necessarily the same thing, we don't ask about family household income or anything like that. But with these two things, these are some demographics we have that we wanted to delve more into the health and well-being behaviors of these students. 18% of our students are facing food insecurity. So we defined that, and we asked two questions in our 2020 survey about food insecurity. So in the last 30 days, the food that I bought did not last, and I didn't have money to get more. And in the last 30 days, I could not afford to eat balanced meals. So for students who responded sometimes, very often, or always to those questions, that shakes out to about 18% of Missouri college students. So again, this kind of as a proxy for economic stability, potentially that community context, et cetera. And then we do have 81% of students in the survey identify as white, about 10% Black, African American, or Native African, about 6% Asian or Asian American, 5% Hispanic or Latino, and then about 3% biracial or multiracial. And again, this is a select all but apply category, so students may fall into one or multiple groups. And again, I want to recognize that intersectionality here, that when we looked at this data too, we see that there are, we'll look on the next slide, but more students of color that are experiencing food insecurity. We typically see that first generation students are more likely to be students of color, even LGBTQAP students. I know Kaylee mentioned, but lesbian, gay, bisexual, queer, questioning, asexual, and pansexual students. So again, these students don't necessarily exist in one bucket and not another. They are potentially impacted in multiple ways and part of multiple groups. So we did break down experiences of food insecurity by racial and ethnic group, and we see that the highest percentage, 40% of our students who identified as Black, African American, or Native African were, again, facing food insecurity. So sometimes, very often, or always indicating those two questions about access to food, not having money to get more, and not being able to eat balanced meals. Also higher, 33% among our biracial and multiracial students, 26% of Hispanic or Latino students, 21% of white students, and then 13% of Asian and Asian American students. So certainly higher percentages among some of our students, some of our racial and ethnic minority students. And then really kind of tying this back to retention and student success. If we're thinking about that these students may have, different demands on their time, these Pell Grant eligible and first generation students may be needing to work and, provide provide additional funding for their education, as well as students facing food insecurity. We do see that if we're looking at average GPA, the average GPA among all Missouri college students is about 3.44, but we see that decrease for students who are Pell Grant eligible, first generation, and certainly for those facing food insecurity. So again, students who are worrying about where their next meal is coming from, the ability to attend class, study, et cetera, is significantly impacted by the fact that they are not, operating at full capacity because they may not be able to have enough food. So we also asked some questions on our survey about flourishing and thriving. So it's a brief 8-item summary that sort of measures respondents' self-perceived success in areas like relationships, self-esteem, purpose, and optimism. So it provides like a single psychological well-being score. So it's on a scale from 8 to 56. There are Likert scale questions that I'll show on the next slide for students to strongly disagree up to strongly agree with, and then a point value is allocated, and then again that single psychological score at the end. But again, things about purpose and having rewarding social relationships, feeling competent and that you're a good person and optimistic, etc. So we see lower flourishing measures again among all Missouri students. The average score is about a 46.05. We see that slightly lower for first generation college students, Pell Grant eligible students, and then again, certainly much, much lower among our students who are facing food insecurity. And then if we delve into that even a little bit further, looking at flourishing scale by racial and ethnic identity and experiences of food insecurity. So we've broken it down into by race and ethnicity in that first column, and then that plus if those students were experiencing food insecurity. So among all of our students, again, 46.05, we did actually see that some of these students did report on average a higher flourishing score, which is great to see. And so certainly when we think about that community context, that probably seems to be a really important factor that may be encouraging, flourishing and thriving at a higher rate. But that food insecurity is impacting. So among those students, for almost all groups, the flourishing score was much lower when you added in food insecurity. Didn't do that necessarily for students identified as biracial or multiracial. Again, recognizing that these students may also have selected within other groups as well. But that was kind of an interesting caveat that we saw in this data. And then our survey does ask some questions again about common mental health concerns, and we wanted to see, if those experiences, major depression, anxiety, and panic attacks are kind of the 3 largest mental health, self-reported mental health concerns that we see among students. And so we wanted to look at those among Pell Grant, first gen, and students facing food insecurity. And for all of these, in all of these groups, I know this is kind of a data heavy slide, but these were statistically significant. So we're seeing 50% of students who are facing food insecurity report that they've experienced major depression in the past year. 71% of students facing food insecurity experiencing anxiety, and 41% experiencing panic attacks in the past year. Again, certainly much higher than their sort of counterparts who report that they are not facing food insecurity. Facing food insecurity really seems to be sort of the greatest predictor again of these. These rates aren't quite as high among students who are Pell Grant eligible or first generation, and these two were much more similar. But so again, facing food insecurity really does seem to be a pretty significant impact on our students' overall health and well-being. And then we also asked some questions about if students have sought assistance for their mental health concern, and then if they didn't seek assistance, what some of the barriers were. And we see that, again, sort of relating back to those social determinants related to access to healthcare, potentially economic stability, et cetera. We delved into some reasons related to high cost, not having insurance, not knowing of any resources. And then we did actually look at this, found the assistance not to be helpful. And for almost all of these, again, we saw that significant difference. Sorry, this is just Pell Grant and first gen students. But we saw that these students were much more likely to report high cost, no insurance, and not knowing resources as a barrier compared to non-first gen and non-Pell Grant eligible. And then we actually saw slightly lower rates of first gen and Pell Grant eligible students reporting that it wasn't helpful. So honestly, more likely that they sought assistance, at some point and had found the assistance not to be helpful. A lower percentage of those students actually reported it compared to non-first gen and non-Pell Grant eligible. Looking a little bit further at sense of belonging to the campus community, again, kind of as a proxy for that social and community context. So we asked students, do you feel a sense of belonging to the campus community? And this is a combination of students who agree or strongly agree. So we say these students feel some sort of sense of belonging. Again, that's 66% for all Missouri college students, but certainly much lower, again, among students facing food insecurity. Only 56% of those students said that they felt a sense of belonging. 62% of Pell Grant eligible, and then 61% of first generation students. And then if we look at this broken down by race and ethnicity, 67% of white students, 62% of Hispanic and Latino students, and then 61% both for biracial, multiracial, and Black, African American, and Native African students. I thought this was really interesting to look at when we see that much lower rates of this sense of belonging to the campus. But again, if we looked back, there were certainly similar or even slightly higher rates of flourishing. And so I think Joan mentioned this at the very beginning, but given that most of our campuses are predominantly white institutions, we have 2 HBCUs in our coalition, but I think this really points to, potentially these students with their campus not feeling necessarily as connected, but certainly within campus finding those spaces, finding, friends and relationships that are much more rewarding, but that doesn't necessarily relate to the campus community as a whole. And they may not view it that way. And so I think that's just sort of an interesting distinction, that even though we ask questions that, might seem like they get at the same thing, we do see those differences when we really break it down a little bit further. And then, so this final data slide that I have really related to looking at stress related to finances among students who thought of leaving school. So we asked some questions about if students had thought of quitting or transferring from their current institution. And then when we ask some reasons why, we ask if it is due to not having enough money to pay for school. And then students who are, again, Pell Grant eligible and first generation. Overall, 45% of Missouri college students reported financial concerns as being a source of stress. So again, we also asked that question about if students had what their stress level was in the 2 weeks prior to completing the survey, and then what are some of their sources of stress. So among students who reported stress due to a financial concern, 43% of them thought of leaving their current college or university due to not having enough money to pay for school, right? Which makes sense. And then so only 12% of those students who didn't report a financial concern had thought of leaving due to not having enough money to pay. And that holds similar too for Pell Grant eligible and first generation students. So much higher percentage of students who are reporting financial concerns due to stress were Pell Grant eligible or first generation students. So again, really wrapping up this data, essentially what we see is that first generation Pell Grant eligible and students facing food insecurity overall have some lower well-being and flourishing measures. And so to us, that really pulls out that economic stability is a really strong social determinant of health for our students. And that, while the social determinants impact people across the lifespan, college might be an important point for students to, again, build capacity for their health and well-being going forward. These are a lot of very large structural issues that are difficult to impact, but we want to do what we can while these students are at our institutions, and we want to make sure that the health and well-being and alcohol and other drug prevention services that we offer are really, going to those students essentially with the most need. And again, this data relates really strongly to retention and student success. So if our students don't have the tools and the support that they need to be healthy and well, they're at greater risk for leaving our institutions. I think that's even more of a point for upper administration. I know a lot of us do this work, right, because we care so strongly about students, and we don't need this reminder about retention and student success. But if upper administration aren't convinced yet that they need to invest in health and well-being, for college students, I think this makes a great case of why we need this and why we, again, need to be thinking really critically about who receives our services, what our services look like, and who they are really tailored for. So some next steps and some sort of encouragement to go forward with this information. I would encourage you to examine any data that you have, whether that's with surveys or focus groups or however you are collecting data on your campus, but just to look at anything similar to this. Again, we don't have necessarily questions about the social determinants of health, but we could look at some things and really try to delve into some data that we have to see what.
Did you get money out? Do you want to go get money out for her? Let's go do that.
Somebody wouldn't mind muting. All right. And then evaluate your campus policies and norms, and really think critically about if they are upholding health inequities, and are your policies punitive? Do they disproportionately impact a certain group of students on campus? Are you seeing more referrals, for students of certain historically marginalized identities? If we aren't thinking critically and assessing, again, the work that we do, then we can't design better interventions. And again, thinking about if, are we tailoring any resources that we have? Get feedback from your students, and we need to always be considering the audience, and really who we're doing this work for, and working with people. And then really too, thinking about health equity and justice, is that a shared vision and value of your institution? Are you having these conversations on campus about the social determinants of health, or about who really needs the services that we offer, and if we're working with and for those folks. And then two, thinking about health in all policies, right? So I think what all of this says to me is just that everything impacts health, everything does. And so if we're framing every decision that we make in what the health impact is, then we can consider how to make healthier environments for our students. So then moving forward to, I think, again, like building that capacity. So capacity is the place where resources meet readiness. And so if we want to build capacity, we have to increase our resources and improve our readiness. I think increasing resources is tough right now, right? And so it's tough to get funding. It's tough to get more things on campus right now. But I think if we can improve readiness, that's a piece of this puzzle. So building and strengthening partnerships across campus and in the community. So really we need to engage diverse stakeholders, right? So if you aren't working with folks in financial aid or academic support services, or if you have food pantry services on campus, if you aren't reaching out to those folks, you definitely should be, and really cross promote your resources. Because again, there may be students who, if they're going to go to one place on campus because they need help and they're going to the financial aid office, they're going to food pantry services on campus, are they exposed to other ways to build their health and well-being, other ways for them to take care of themselves or access these other services? So I think building those partnerships is really key. Also training, right? So part of improving readiness is developing and strengthening a prevention team. So are we training on the social determinants of health? Are we talking about health inequities? Are we doing anti-racist and anti-sexist, all of this other work? Are we talking about trauma and how experiences of trauma early on, ACEs and the adverse childhood experiences, about how that's impacting our students before they ever set foot on our campuses? Are we cross-training, prevention folks from different backgrounds? All of those things really important. And then finally, raising awareness is a piece of improving readiness. So as much as we can, right, including that equity lens and then a racially conscious framework in the work that we do, and thinking too about how can we leverage, again, those evidence-based policies in non-health sectors that address the social determinants of health and health outcomes. So funding food pantries on campus, promoting safe and affordable housing, accessible transportation for folks. So if you're hearing these conversations from students about lack of affordable housing or lack of accessible transportation, that's a health issue, and we need to again work to fix those inequities in order to improve health. And then finally, kind of a next step individually, right, is doing the work. So continuously evaluating your attitudes, beliefs, and behaviors. I saw a speaker a few years ago just talk about being an anti-ist. And if you can do one thing every day, reading, learning, watching, whatever it is, but continuing to do that work. And again, leveraging any power or influence that you have to stand up in support of those experiencing oppression and amplifying the voices of others, right? We're really wanting to listen, again, amplify. We're not talking about being, white saviors and uplifting, people to make ourselves feel better, right? It's about creating those better systems that work more effectively for people. And again, with people. We aren't doing this for them, we are doing it with them. And again, advocating for those folks as well. So these are some really, really incredible books that I would recommend. If you have not heard of these, I would highly suggest any one of them. They're all really fabulous. So I just want to throw those out there, that these are some really incredible resources. And then again, some of these resources up top that have been created by things like SAMHSA and CAPT and other organizations, and then some of our Missouri Partners in Prevention resources. So we have our research briefs. I think Joan posted that link earlier. We also created a book list that has some of those books and other things that we would recommend. We do have a health equity toolbox on our website. And we've also created a coalition building toolkit. And all of these have links. I'll make sure to put them in the notes when I share the slides as well. All right, and that really wraps up the portion of my presentation. Again, here's my contact information, but you can get a hold of me through Joan, Kaylee, our PIP email, whatever that looks like. But I'll pause here if there are any questions or anything. Oh, and someone's saying, can you please put the books back? Yes. All right. But yeah, I will pause here again if anyone has questions or anything you want to chat about. I think we still have a little bit of time.
Margot, would you be able to put in the chat your videos that you shared? We had some folks asking about.
Yes, I will do that here. Let me pause.
Any questions for Margot or Kaylee before we very quickly preview what we're going to be doing on Thursday? So just a note, as we continue to potentially get some questions in the chat, we set up today to really set the stage for the fact that, again, we're not going to be going back to the way it was in 2019 and 2020. When we think about moving forward with our alcohol and other drug prevention work, or really any health and well-being work for our campuses moving forward, things are going to look different, and we now know better, and so we need to do better. And so that is part of the reason why we shared some of the data that we had and some of the health equity work that we are pushing our campuses forward with. And I think that Kaylee and Margot did an excellent job of setting that stage. And so we will talk on Thursday more about using the strategic prevention framework and how we can move forward with an equity lens as we select programs, knowing how COVID-19 has affected our students, as well as the dual pandemic that our students have been facing. So the three of us will stick around for any questions that you have. We want to thank you, and we look forward to seeing you at 1 o'clock on Thursday Central Time.
While we're waiting on questions, I just want to remind everyone that if you want to receive CHES credit for attending these events, please make sure I have your CHES number. You can email my email that's attached to my name or right here. So just wanted to remind everyone just in case.
Orlando, do you need anything else from us?
I do not. It seems
Okay.
like no one has questions, so I'll see everyone Thursday.
Okay, thank you so much for your time.
Thank you.
Thank you.